18-FDG PET-CT provides the clinical foundation for localizing metabolic disease. Clinicians rely on it to evaluate metastatic spread and measure a primary tumor's exact extent. Look at this fused image. Right over the heart, there is a blindingly bright, localized hotspot. In the context of a cancer workup, this aggressive focal uptake signals highly metabolically active, malignant tissue. Except there is no tumor there. That glowing mass is a complete fiction generated by the machine's software in response to a standard metallic pacemaker. The hardware algorithms and metabolic pathways engineered to isolate malignancies are highly volatile. When perturbed by common physiological states or foreign hardware, routinely manufacture severe false positives and mask deadly false negatives. To accurately interpret the standardized uptake value, the metric used to quantify radiotracer absorption, we have to look past the final glowing image. We must deconstruct the subatomic physics, the hardware attenuation algorithms, and the radiotracer's underlying biochemistry. The final image is a mathematical estimation of competitive cellular metabolism, shifting based on the software's physics compensation and the patient's internal state. The process begins with the radiotracer. 18-fluorine is produced in a cyclotron. Decaying into 18-oxygen, it undergoes beta-positive emission, ejecting a single positron. That positron travels a short distance before colliding with an electron in the patient's tissue. This collision causes an annihilation event. Their mass is converted into energy, producing two 511 kilo-electron-volt photons firing outward in opposite directions. The PET scanner is a ring of detectors. When those photons hit the outer ring simultaneously, the computer calculates the precise geometric origin of the collision. To give these coordinates clinical context, a CT scan is fused over the raw PET data, providing an anatomical map so the radiologist knows exactly where that origin point lives in the body. But the CT has a secondary, hidden role called attenuation correction. Dense bodily tissues naturally slow down or absorb the outgoing photons before they reach the detector. The CT software attempts to account for this physical barrier. This chart shows how the algorithm reacts to varying tissue densities. When photons pass through dense foreign objects, like a metallic pacemaker, they are severely attenuated. The software reads this high density on the CT and exponentially multiplies the PET signal to compensate. The computer overcompensates. By artificially inflating the signal to account for the metal's density, the algorithm creates a glowing pseudotumor right on top of the hardware. The clinical protocol to avoid this specific artifact is rigid. Whenever you identify a highly suspicious hotspot, you must verify it against the raw, uncorrected source imagery. Relying exclusively on the corrected fusion imagery allows the machine's physics compensation algorithms to manufacture disease out of thin air. Moving from hardware physics to molecular biology, we follow the 18-FDG molecule as it travels through the bloodstream and approaches the target cell membrane. FDG is a glucose analog. To breach the membrane, it uses the exact same cellular gateway as normal sugar, the GLUT1 transporter. Once inside, the cellular machinery takes over. The enzyme hexokinase phosphorylates the FDG molecule, structurally altering it into FDG6-phosphate. This specific transformation acts as a lock. The molecule can no longer fit back through the GLUT1 channel. The radiotracer pools, physically trapped inside the cell, where it can be measured. We measure this accumulation using the standardized uptake value, or SUV. This number describes exactly how much FDG a lesion drinks. Clinically, values above 2.0 or 2.5 are flagged as abnormal, indicating high metabolic activity. This brings us to a critical biochemical vulnerability. If the patient is hyperglycemic, their blood is already saturated with massive amounts of native glucose. This triggers competitive inhibition. The native glucose molecules aggressively outcompete the sparse 18-FDG molecules for access to the finite number of GLUT1 transporters on the cell surface. This bottleneck physically starves the tumor of the radiotracer. Because the FDG cannot enter the cell, it cannot be trapped, and the measurable SUV plummets. A cold tumor on a PET scan does not guarantee an absence of cancer. Often, it means the patient's native physiology has simply outcompeted the radiotracer, effectively masking an aggressive malignancy. Faced with a hyperglycemic patient, the seemingly logical clinical fix is to administer insulin right before the scan to lower their blood sugar. But insulin is indiscriminate. Its systemic mechanism drives all circulating glucose directly into skeletal muscle tissue, and it takes the FDG tracer right along with it. The resulting scan is useless for oncology. You see a diffuse, intense uptake saturating the patient's skeletal muscles, draining the radiotracer away from the internal organs you are trying to evaluate. There is a second form of physiological hijacking, driven entirely by environmental stress, the activation of brown adipose tissue in cold or anxious patients. Unlike standard white fat, brown fat is dense with mitochondria and wired with sympathetic innervation. Its primary biological function is to aggressively burn glucose to generate body heat. When a patient is cold or nervous, this tissue activates and drinks the radiotracer. It produces intense false positive uptake, heavily localized in a specific anatomical pattern, at the base of the neck, across the shoulders, and along the paraspinal fat. Mitigating this requires environmental and pharmacological control. Technicians keep the room warm, place the patient on a high-fat, very low-carb prep diet, or administer adrenergic blockers like propranolol to suppress the sympathetic response. Without strict control over the patient's environment and chemistry, their systemic metabolic drive overwrites the tumor signal. The oncology scan degrades into a simple map of thermal regulation and anxiety. The exam's utility lies in identifying distal metastatic spread and determining the total volume of viable disease. SUV metrics cannot be trusted blindly. They must be verified against the physical hardware density found in the raw, uncorrected CT data. The interpreter must also account for the biochemical state of the patient at the time of injection, factoring in systemic glucose competition, including insulin dynamics and sympathetic nerve tone. Ultimate diagnostic clarity is not achieved by trusting the machine's software. It is achieved by systematically deconstructing the physics and physiology that generate the image.